clinical oncology, and we welcome everyone here who's in Nashville live today, as well as those joining us on the internet on the webinar, which I'm getting the thumbs up is live and active, so that's good to know. If you have other colleagues who are at home or in the office, let them know they can join on and listen in and view our presentations as well. These will also be, the next few sessions will also be recorded and available after the fact on the Tennessee Oncology Practice Society website and the ACCC website. So thank you. A quick reminder, please turn off your cell phones, ringers, to avoid interruptions. And this is an interactive meeting, so there will be time for questions and answers, so jot down your questions and there will be time for that, and please let us know what you're thinking. So again, welcome. I'd like to just go ahead and introduce our first speaker at this point, Dr. Joseph Kim, who will be speaking on trends in oral oncolytic treatments. Dr. Kim is president of Q Synthesis, a healthcare quality improvement consultant, and has been working with ACCC on a number of initiatives, and is also faculty with the American Association for Physician Leadership, among other things. So I'd like to welcome Dr. Kim up to speak.
Thanks very much. So it's a pleasure being here, and I want to thank you all again for giving me this opportunity. And since this is a webinar, as you know, as Greg mentioned, we're going to have some interaction throughout, and keep in mind that your comments and everything else that's going to be spoken is going to be captured and recorded. So this presentation, Trends in Oral Oncolytics, is actually a first webinar that we're presenting as part of a project that ACCC is engaged in, and I want to just share with you what this project is all about. There's a project called Steps to Success, implementing oral oncolytics, and this project is focusing around how oral oncolytics are initiated in community-based settings throughout the country. We understand that the trends are going to vary based on the demographics as well as the resources that are available per cancer program, whether you are a NCI-designated center versus a community-based center versus an outpatient oncology practice. So we want to look at different organizational approaches and processes really around the multidisciplinary care team. What's happening when these patients are being treated with these oral oncolytics? How's communication occurring? How's care coordination happening? And what can ultimately be done to make that whole process better? So there are several elements involved in this project, and as an educational consultant, I'm working very closely with ACCC on this. We've now conducted a membership survey, so I'll be sharing with you some of the findings from that membership survey. And then here this month, as well as next month, we're going to be performing some focus groups with select cancer programs throughout the country, getting a little bit more in-depth information about how they're initiating these oral oncolytics. Following that, you'll see an article in Oncology Issues, and then you will be hearing about more webinars throughout this year. So we know that when we look at the current state and compare oral versus parenteral chemotherapy, there are a lot of processes that are similar in the sense that there's prescribing happening, there's patient education, then there's the whole dispensing component, and then how do you monitor and follow up with these patients? And I think traditionally everyone here knows that when patients come in for their visits, they're sitting in the infusion chair, you have that face time with them, you can ask them questions, you can physically see them, and really evaluate how they're doing. And plus, when it comes to education and monitoring, that's happening on an ongoing basis. You've got actually that physical contact. Whereas we also know that when it comes to oral oncolytics, many times these patients are getting medications at home. We don't even know if they've received their medications, if it's coming through the mail. So how can community-based oncology practices, how can they improve this whole process of caring for these patients throughout this continuum? And so we're going to be diving into some of these issues, and I want you, as you're sitting in your chairs, to think about what is happening within your own practice setting and who's doing what. And perhaps in some cases you know exactly what different people are doing, and in other situations perhaps you're not really sure who takes care of that part, or how's that process occurring. So the survey that ACCC ran occurred in March of this year, just a couple months ago, and what we did is we wanted to get a diverse representation of the different kinds of cancer programs that are out there throughout the country. We know that today, especially, there's that designation of, are you an academic center versus a comprehensive community center? The lines are kind of getting confused because more and more practices are either getting acquired or they've got these affiliations and partnerships. So we understand that some interpretation here is required, but you'll see that the vast majority of the representatives of those who responded to the survey are coming either from community cancer programs or comprehensive community cancer programs. We have about, and we'll talk about that in a moment, but actually here this just highlights who responded to the survey, so what is their professional role. And you'll see 35% were pharmacists, another quarter or so were nurses, nurse coordinators. We also had a large percentage of cancer program administrators, and medical oncologists were 7%. And this, based on the COC accreditation standards, we wanted to know what percentage. So you'll see that over half were from these community cancer programs that were either comprehensive or standalone community cancer programs. And then about a quarter to a third represented academic/NCI designated centers. And then we also had a big percentage of folks who came strictly from outpatient oncology practices. It's a very diverse mix of of stakeholders responding to the survey. And we wanted to know first, what percentage of your cancer patients are receiving their oral oncolytics either through a in-house dispensing pharmacy, a mail-order specialty pharmacy, a retail pharmacy, or some other source. And this slide might be a little bit confusing to understand, but what I want you to look at are the lower colors, of the red and the green, which really represents the bulk of the cancer patients who are receiving oral oncolytics. And you'll see that if you look at the red and the green section of the in-house dispensing and compare that to the mail-order specialty pharmacy, there's a lot more patients in the community getting their medications from mail-order specialty. And I think, is this a trend that's going to continue? Is it going to grow? I think there's a lot to be said because it really depends on the disease state, the drug, the manufacturer. There's so many components that factor into this. And what we're also finding is that many of these cancer programs in the community don't have, for instance, a pharmacist on staff. So, can they coordinate with someone or can they work with someone locally? Or are they primarily relying on these specialty pharmacies that are external, that are outside somewhere else for that level of expertise and that service? And I think that is an interesting trend that, once again, is largely geographically driven. We also asked survey respondents, in your cancer program, if patients are experiencing delays receiving their actual oral oncolytics through mail order, what are some of the reasons for those delays? Do we know what those are? And the two biggest ones were that the specialty pharmacy system took too long to process the order, and then the second was denial from health insurance. So not too surprising there, but you'll also see that things like the lack of documented pre or prior authorization, as well as the incomplete patient clinical documentation that's required, are process issues that certainly can be addressed if you take that sort of proactive approach and ahead of time that, hey, these things may cause delays. Let's make sure that we proactively address them so that when the order is placed through the system, that we can reduce those delays and make sure that patients are not waiting around. In some cases, we also found that the order was not being processed correctly, and there were a number of reasons for that happening. And then there was a list of other reasons that, that we'll certainly get into later on. But I think the reality becomes, in many situations, as I mentioned before, there are delays, and the oncologists, the nurses, the other providers in the care team often don't even know, has my patient received his or her medications. We asked the program, does your cancer program have a formal oral oncolytic program or protocol? And this is subject to interpretation, but we wanted to sort of outline some of the key elements like, patient education, treatment initiation, monitoring for adherence and toxicity, as well as making dose adjustments. And we found 43% said, yeah, we've got a program in place. Another, 17 said, yes, but only some of the components are in place. And then everyone said no. We're either in the process of developing one and implementing it, or no, we're not there yet. So you'll see that I guess, here within this audience too, I'm sure depending on your setting, whether you're coming from a hospital-based system, an academic versus an outpatient or a smaller system, you might be in different places along this continuum as well. And depending on how you define that protocol, if you will, or program, I'm sure is going to continue to vary and evolve. And some of the issues that we're going to dive into as we look at the rest of the survey results might help you reflect on, is our program robust enough? Are we covering all the bases, or are there other areas where perhaps we can make some refinements and improvements? We asked programs, who leads your oral oncolytic program or protocol? And in many cases, it was either pharmacists or the oncology nurse who really took that leadership role, who spearheaded the initiative and who played that leadership role. In many cases, we are also getting feedback that it's a team-based approach, but ultimately someone has to be that lead. And whether that person is a lead in patient education or someone is a lead more on the process side, that also kind of varied. But you'll see here that those were two critical roles and two very important ones, and something, certainly advanced practice providers as well as the medical oncologists are playing lead roles in many places as well. But this is an interesting sort of baseline trend. And then we asked some open-ended questions like, what are some of the top barriers or challenges that your program is facing? Very open-ended, people could just share whatever they wanted to. And we wanted them to list, their top 3. So here's just sort of a conglomerate summary of some of the free, text comments that came in. And you'll see certain trends, like insurance and, pharmacies and staffing resources, cost and compliance. And if we sort of distill this down and look to see, all right, well, what are some of the top ones? Are there certain themes that are coming up over and over? I think everyone knows that, yeah, the out-of-pocket costs, the patient access issues, that's something that we're all, dealing with. We're looking for ways to improve on that. And I think everyone is sort of universally in that same boat. And similar to that, prior authorizations, dealing with insurance companies, that also really varies depending on, once again, where you are in the country and who you've got contracts with. And then everyone universally also said, monitoring for adherence and toxicity, we're struggling in that area because we're not really sure how effectively to do that. And some of our patients, they're tech savvy, they're willing to communicate with us electronically. In other cases, we're requiring to make a lot of phone calls, and we just don't have the staff, the personnel, the training in place to make that happen. And then medication delivery delays, because so many of these programs are dependent on these mail-order specialty pharmacies, as well as the fact that now they're dealing with multiple different specialty pharmacies. Even those programs that have in-house dispensing specialty pharmacies might still be dealing with other specialty pharmacies for specific products. And so that whole process, they can't just streamline and have a single process in place. They almost need to customize the process based on what the product, the drug that the patient is going to be receiving, and figuring out how is communication, monitoring, adherence, how are all those things going to get coordinated. When initiating these oral agents, we asked, who provides the bulk of the education to the patient? Because we know that fundamentally patient education plays such a critical role in not only preparing the patient, but also engaging them. And what we found here is that, some interesting trends, not a universal one, but 18%, where it's really that medical oncologist who provides the bulk of the training and the education, 12% saying, yeah, it's advanced practice providers, 30% saying oncology nurses, and 20% saying pharmacists. But I think a trend that perhaps might be growing, particularly for the larger programs, is the 13% up in that upper left-hand side, which says, we take a team-based approach. In addition to the medical oncologist explaining the disease state and all the different treatment options, when it comes time for the patient to learn about his or her medication and what he or she is going to need to do at home, from safe handling to dosage adjustments and everything else, we actually use a team-based approach. And so as a team, we sit down with that patient. We've got a pharmacist, a nurse, or whoever's part of that team, and we spend a lot of time right there in the office setting with that patient. And then we establish points of contact throughout when the patient goes back home. So once again, I think it's a novel approach if you've got the resources and the expertise to provide that to your patients, but in many cases, not many programs have that, to be able to do all of that internally. And I think especially today where, you can leverage telemedicine and telehealth communication platforms, would it make sense to perhaps have someone like a pharmacist available on a video screen while the nurse is in the room, and so both people are talking to the patient simultaneously? Or could there be other sort of modalities of patient education and engagement that perhaps might work in today's age. We asked the question, how often are these topics being brought up when educating cancer patients about these oral oncolytic agents? And we know that, groups like ASCO, ONS, and others have established sort of that standard of, what are the topics that need to be covered. But you'll see right in the middle, so the dark purple and the blue on the bottom represents where most people said, yeah, we're covering this most of the time or always. But right in the middle of this graph, or this slide, you'll see drug-drug and food-drug interactions, as well as plan for missed doses, are the two areas where people are saying, yeah, we're not doing a great job in these two particular areas. We're doing fine in patient diagnosis, goals for treatment, sort of all the bread and butter topics of patient education, if you will. But when it comes to these two areas right in the middle, I think that's where we see both gaps as well as opportunities for improvement. And I think in reality, the fact becomes, particularly for those drug-drug interactions, unless you have a pharmacist reviewing the medication list, doing that med rec if the patient is leaving, say, an inpatient setting, and really assessing and understanding that, yeah, with this particular oral agent and this list of medications, these are potential interactions that we need to be looking out for. Without that level of expertise and that review and oversight, that's going to get missed. And then in terms of the plan for missed doses, I think people are often not really sure exactly how to direct the patient there. If the patient misses 1 dose versus 2 versus 3, what do they do? So I think there are protocols that need to be built in, but also we have to keep in mind that that protocol is certainly going to be dependent on each drug that the patient receives as well. We asked a few other questions. How do your clinical staff members monitor for adherence and toxicity? And I think this is something that also really varied. We gave them several options to choose. Everyone certainly does schedule follow-up visits, and they're making a lot of phone calls. Patients are instructed to call, but when it comes to the opportunity of using electronic communication, we saw that that was very, very small. And, throughout the country, as I've been involved in other types of process improvement projects in oncology, what we're finding, particularly in community settings, is that, yes, everyone has an electronic health record, and they may or may not have a patient portal because of meaningful use, which now we know is going away with MACRA and everything else. But many of the small to medium-sized community cancer programs that even had a patient portal, they really didn't use it, and they didn't really encourage their patients to use it. And part of that might have been because usability was poor, or there were some glitches and problems with it. Part of it might have been the patient demographic. But I think that this might be a missed opportunity here, because that electronic communication with patients, once again, depending on where you are in this country and your patient population, could be a very effective way to assess for adherence, to monitor patients, and to provide that level of communication that's much more convenient and perhaps ultimately gets automated into your electronic record system. But a lot of people today, I think, are avoiding it, and they're probably avoiding it intentionally. So, is that a missed opportunity? Perhaps that depends on what kind of system you have in place, as well as, how you all communicate with your patients. So we asked, what are some ways that your program could ultimately improve in this area? Because after asking all of these questions about, what are you currently doing now, and how are you staffed, how are you resourced, we wanted to get a sense of, what are the key areas and opportunities for improvement. And you'll see, once again, with this, this word cloud, it really points out, and the large words are words that were just repeated over and over when people were given the opportunity to just free text in whatever they wanted. And things like adherence, documentation, monitoring were common themes that came up over and over again. And when we actually summarize some of those open-ended responses and try to get some more in-depth feedback about, what is actually happening out there and what are they doing next? Where are they going to focus their efforts on improving? What we found out is that more and more programs need to formalize their policies. They need structured protocols in place, and they're even referring to these as documentation pathways as opposed to clinical pathways. They want this to be something that permeates the entire organization and not just one group of physicians versus another. They needed more consistent follow-up calls and follow-up methods because, once again, the way that this follow-up and the monitoring was happening wasn't being consistent, and the documentation part of that too was also missing. many programs emphasize the need that they need a dedicated staff who's just going to focus on monitoring these patients who are placed on oral oncolytics. So what does that look like, depending on how big your program is and what kind of staff members you have, as well as access to pharmacists on site. Earlier I mentioned a lot of this is missing. Cancer programs throughout the country, I think, are experimenting with different ways of communicating and engaging with different pharmacists. But are they establishing and building the kind of relationship where they can, for instance, have that pharmacist access patient records? And that really varies. In some cases, pharmacists in specialty pharmacies have access to patient records and can review med lists and problem lists and everything else. But in many cases, they don't. For various HIPAA and patient privacy regulations, they don't have access to that information. So then they're almost like working in a bubble. They're sort of isolated, and so they've got only limited information, and those pharmacists can only provide so much guidance or so much input. So how can that change and how can that evolve? And ultimately, also things like structured assessment forms, checklists. I think from a formal process improvement standpoint and methodology, those things are certainly needed. When we asked the question about abandoning treatment, there's been some interesting things published in the literature about this, due to financial toxicity and just the need of out-of-pocket costs. What we found, fortunately, is that there's not a huge trend, at least amongst these respondents, of patients who are abandoning their treatments completely. But there are some, and I think that is the reality. So, about half said, yeah, less than 10% of our patients are probably abandoning their medications because the costs are just too high. But then about a quarter said, yeah, we would probably estimate that it's between 10 to 30% of our patients. So I think there's an opportunity here to make sure that, once again, we're proactively addressing that cost issue. And I think there are many ways of addressing the cost issue, and we'll get into some of those things. ACCC, as you may or may not know, has an entire financial advocacy initiative, and I'll be talking about that in just a moment. But one of the big pushes that's happening right now are these financial advocates or counselors. Some people may call them financial navigators. And more cancer programs are bringing these people on board. They're training them, they're equipping them to play a key role in assessing these patients and guiding them through the different resources that are available. And I'm not just talking about patient assistance programs or free drug and drug replacement. These financial advocates are doing much more than that. And so we asked, how many, if any, financial advocates or counselors do you have in your program? And this is a trend that I think ACCC has been following and really trying to push to grow the number of resources that community programs as well as hospital-based and large cancer centers are having and investing in. And you'll see here that the vast majority said, yeah, we have probably less than 5 dedicated financial advocates who are working with our patients. And that number probably really needs to increase if we believe that oral oncolytics are going to increase and that the burden, the financial burden, Medicare Part D as well as out-of-pocket costs and everything else is going to just increase for these patients. So in terms of tools and resources that programs felt would be most helpful, you'll see that a lot of them focused around things like assistance programs as well as patient education and information. And in terms of what they're using, we asked them, what kinds of resources do you use? And it ranged. A lot of them are using society-driven pamphlets and educational tools. Many of them are also using tools provided by pharmaceutical companies. But here, you'll see that this is really the list, this is the wish list of what they wish they had at their disposal. And it ranges from things like, the structured information education that we talked about, to video tools for education, care plans, printed forms, questionnaires, cheat sheets for requiring, the required monitoring parameters, if you will, and the things that they need to enter into their for documentation, as well as more starter packs and pillboxes. I think, some have more access to those than others. And then the side effect management guide, I think, is something that different programs are providing that information to their patients either through a structured approach or in many cases just providing patients a lot of information and hoping that those patients will retain some of that when they go home. So I mentioned to you the ACCC Financial Advocacy Network, or FAN, initiative. There are a number of resources on the ACCC website, including some survey results, an assistance and reimbursement guide, And then there are these workshops that ACCC has organized. So just in a few weeks, we're going to be in Cleveland, Ohio, conducting an interdisciplinary workshop for members of that financial advocacy team. And by that, I'm referring to everyone who is involved in that whole process of assessing, doing perhaps a psychosocial assessment, a financial toxicity screening, if you perform that kind of screening. So social workers, caseworkers, nurses, nurse managers, even nurse navigators, all the different folks who are involved, even the billers and coders to some extent, because when that bill goes out to the patient and the patient doesn't understand it, and then they're now calling back frustrated, upset, and it alters and skews the patient experience, surveys, all of that is tied in to that whole patient experience. So we've got these workshops occurring. There are other things that ACCC is organizing as well. There's a certificate program for these people that we'll be developing and launching in 2017, as well as other educational resources. So keep this in mind. This is something that is very, very valuable and important. And then in terms of the key opportunities for improvement, I just want to highlight some things that have been published in the literature that I think help set the stage of where we're going to be going next with this whole oral oncolytic project. So we know about ASCO and COPE, and this was a paper that was published last year where data from 155 oncology practices that participated in COPE looked to see, how are they doing as it relates to oral oncolytics, and particularly around documentation. And of course, when it comes to documentation, we all know that depending on your EHR system, some of the documentation fields are structured. It's easy, you just click, 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 and then you can easily extract that information. And in many other cases, it's unstructured, so you have to manually go through and see, was this described, or did they discuss this, or did they cover this topic, and it's much more labor intensive. And what they found was that 66 to 68%, were doing fairly well in terms of that's their mean composite score for treatment plan documentation, and we'll get more into the specifics of what that actually means. The score for patient education was closer to 50 to 57%, whereas those around adherence and toxicity monitoring was 75 to 81%. So what does that mean? What it means is that when they looked specifically at certain metrics specific to documentation of the treatment plan, patient education, as well as adherence and toxicity monitoring, the ranges you'll see in the blue where they were doing well, and then sort of in that yellow section where they felt like there was room for improvement. So for instance, documenting dose, just about everyone was doing that. But when it came to actual lab and toxicity monitoring, only half had that documentation in their EHRs. Also in terms of the frequency and visits and contacts, how was that part of the treatment plan document that was documented in the EHR? Once again, only half of them had that documented within that treatment plan section. When it came to patient education, once again, adverse effects, toxicities, schedule, start dates, doing fairly well there, but documenting what patients should do if they miss their doses, as well as the safe handling issue, and then the food and drug interactions, we saw less than half of that documentation was present. So kind of similar and reflective to the ACCC survey where, once again, when it came to that patient education component, and we asked, what are you covering all the time, or most of the time, and what are you not covering? That whole drug-drug interaction and then missed doses seems to be a real big area. So even if it's being discussed with patients, that information isn't being captured in the record. And I think there's some opportunity for improvement there. And then finally, in the adherence and toxicity monitoring, they're all assessing that and documenting that well. But when it comes to adherence, and how are they actually measuring adherence and documenting adherence in the EHR, chances are they're at least talking about it, but not everyone's documenting it. So, today we're living in a value-based world. There's greater transparency than ever before in terms of quality measures and performance, and I think fundamentally this whole documentation becomes increasingly important. We don't want to get into documentation overburden, but I think it's really important to see what has been documented as well as what needs to be documented. So I think, as I mentioned earlier, this project is something where we are just in the early stages. And I want to thank Pfizer again for supporting this project for ACCC, and then there with you all, where we are in this project as well as where we're going. And hopefully, the findings that we discover through these focus groups, the interviews, some of the survey information that I shared with you, some of those nuggets of information will be generalizable and applicable based on where you all are. Others, I think, are going to really be contextualized based on your sort of composition and makeup of your cancer program. But it's really our hope to not only understand what's happening out there, but can we find some of those best practices? Can we find those key opportunities for improvement? Not just so that we can check the box and say, yes, we're documenting this, but ultimately so that we can improve that patient experience and the patient outcome. They need better access to their medications. We need to improve how we're communicating with patients, and that whole monitoring, documentation, adherence, and toxicity needs to improve as well. And I think that's really the hope of this project. So with that, I want to sort of pause and see if there's some either questions or some interaction that we can have. We've got a microphone, so are there questions, comments?
Doctor, can we? Oh.
And then also, if there are questions from the webinar participants, they can actually use the chat function to submit questions. And as I mentioned earlier, this is just the beginning of this project where we're going to be having more, in addition to the article that's going to come out, webinars later on this year. So, yes.
So thanks, Dr. Kim, for a really nice presentation. But much of what you've spoken about and many of these activities, you realize, are in the current payment methodology are basically unfunded activities. With the oncology payment model and ASCO's suggested payment reform and some other models, there are resources built in to compensate practices and to compensate centers for providing these services. But currently, the resources that we utilize in the private practice of oncology are not insignificant, and it's almost like the physician who prescribes these medications is then not only expected to provide the expertise and knowledge about who needs these medications and how much and how often, but then all the resources that surround helping the patient to simply acquire them is really quite costly. And it's almost as if, it's like when we order an MRI or a PET scan, we then have to do the prior authorization for our radiology colleagues who are providing the service and being compensated for doing the scans. So I think and part of the problem, and you touched on it a little bit, but part of the problem certainly in the private sector is simply having the resources in your practice to provide all of this assistance. And I think that's something that until we fully reform the oncology payment system, we're going to continue to struggle with.
It's a great point, and I think we're seeing more and more of that being expressed, particularly like you mentioned in the private sector. I think some of the changes and I guess the evolving areas throughout the country is, how is that team, the oncology team, the makeup of that team, as well as the specific roles and responsibilities across members of that team, how is that optimally going to be structured to maximize in terms of efficiency, productivity, et cetera. And I think that might be an area where it's worth exploring because the makeup of the teams really vary, as well as the scope of practice laws per state. But it's definitely a very valid point, and I guess the question now becomes, when are we going to see some major changes to help those in the private sector?
Yeah, Dr. Kim, Steve Grubbs from ASCA. That was a very nice talk. I was in practice 9 months ago in Delaware, so I was using all these drugs. And I tell you, when you showed where we were missing in terms of documentation, one of the huge challenges I had with all these new oral oncolytics was keeping track of what drug needed what tests and when to do it. And I'll tell you, if we could develop some decision support tools for practices, I think that would make a huge difference. Honest to God, I had to look them up every time to say what labs when, because every new drug now has a whole new set of batteries and the frequency to do the testing. It really is pretty confusing. Yeah, it's a great point. We'll certainly keep that in mind. I think some of the EHR systems out there are great at building some of those pathways in and sort of optimizing and automating some of that. But as we all know, not everyone's on the optimal EHR. So how can we improve that? We'll certainly keep that in mind.
Thank you. I'm Karen Fortune. I just wanted to comment. I was attending the Hematology Oncology Pharmacy Association meeting this year. I am an oncology pharmacist. And this was also discussed at that conference as well, and related to resources and FTEs and expense and who's the best person to be that financial advocate. A lot of centers are implementing, especially in the private sector, are implementing pharmacy technicians in that role due to their background related to pharmaceuticals, but also related to the cost of that FTE.
Mm-hmm. Yeah, and the financial advocacy landscape, I think, is continually evolving, where different people are pulling people in. In many cases, they may be taking people who've got a clinical background, training them in some of these financial roles. In other cases, they're working with social workers and guiding them around some of these assistance programs, and so that they can help patients. So it's really an evolving area, and I would encourage you and you to tell everyone in your practice about the resources that ACCC has, because it might give you some interesting new ideas of how you can provide better guidance and support for your patients.
I was intrigued by one of your comments about improving patient education. Whether there's going to be reimbursement or ability to do this or not, I don't know. But one of your comments about maybe a pharmacist could, at the point of care when oncologist is prescribing an oral medication, be brought in by a video conference or something to talk with the patient. In my practice, I'm a medical oncologist, and education for the patients happens about equally between me, one-on-one, and an oncology nurse, and then if their insurance happens to allow the patient to get a medicine from a pharmacist or from a pharmacy that is dedicated to providing education, then also time from the pharmacist. But I don't know what happens in those other interactions, and I don't always know how to access what happens in those other interactions. And as the doctors, we have the information about how the patient's doing and what they're telling us and their side effects and whatnot. The nurses have the tools on dealing with day-to-day tips on management. The pharmacists have the information on drug interactions and efficacy and dosing and what to do about missed doses and things, but that information doesn't come together. So if you come across examples of cases where practices have used video conferencing or just at the point of care better communication, we need to know about that.
Yeah, no, I think it's going to be an interesting question based on, I guess, the comfort level of the practices and, who's going to be the one doing the monitoring and the follow-up with the patients once the patients go home, because in almost half of these practices, it's the pharmacist who does those phone calls and monitors and asks the patient, how are you doing? Are you taking your pills? And if the patient is getting that relationship with that pharmacist and gets to really know that person, ideally, he or she should at least know what the person looks like. But I would say half the other practices, it's really that nurse or the advanced practice provider who's making the phone calls, doing the monitoring and the assessment. So I think, hopefully, I think technology traditionally has been, it's been positioned as an enabler, but in many cases it's been a barrier. And hopefully this will be a project where we can look for some tangible and concrete ways where it can really be an enabler and improve that patient care coordination. Yes, Daryl?
Dr. Kim, we've got some questions from the webinar, and that was actually Dr. Shepard's point about the education of the team. There was a lot of people asking about that. Somebody wants to know, what are the most prevalent oral oncolytics that are out there right now?
Would someone else like to take that question? So I am not a practicing oncologist. I'm probably not the right person to be responding to that question. Is there anyone who'd like to volunteer? Otherwise, we'll have to perhaps follow up. What is the most prevalent oral oncolytic out there? So CML, prostate cancer, and then the last one. So the heme malignancies. Okay.
And they want to know, can patients be charged separately for these supportive services to enable them to get an oral agent?
Can patients be charged? Yeah, so I guess maybe it's a question around reimbursement and
The general rule is you can charge anything you want. The big debate is what you'll get paid, and so
Right.
what you charge is totally irrelevant. But no, there are not current reimbursement programs for these kind of ancillary services that physicians and universities provide when they for the financial advocates, for pharmacy services, etc. So not individual payment things.
Right.
and it's just not built into the current coding system. But it will be bundled into these episode of care-based payment systems that I alluded to a little earlier. And as we have developed, I was on the ASCO committee that looked at their payment reform project and certainly the oncology care model from Medicare. These things are built in, just like, for example, patient education regarding intravenous cancer drugs. There is money, there's money built in there in the form of RVUs in the drug administration codes. So while there are not individual payments currently for patient education for outpatient intravenous chemotherapy, it's not built in as a separate code. There are small amounts of RVUs built into every one of the drug administration codes that cover the cost of a nurse typically or sitting down with a patient to do one-on-one patient education.
Right.
That sort of thing doesn't exist with oral oncolytics, but in the new payment models that are episode-based, those kinds of things are sort of going to be bundled in.
Right, and I know later on today we're going to be hearing about MACRA. So through CMS and MACRA, there are a number of things that are evolving there, and I think there are going to be points for things like care coordination, as well as what they're calling clinical improvement activities, like providing 24-hour care and access for patients, as well as extending your office hours. So all of those things could be tied in to making sure that patients are not only educated, but that they have the proper channels of communication if something happens in, say, the middle of the night or on the weekend. Great. Well, I want to thank you again, as well, those here as well as those on the webinar. And like I said, stay tuned because we're going to be hearing more about this project as we roll on later on this year. And then we will be having more webinars later on this year as well on focused topics specific to oral oncolytics. So please make sure you stay tuned to those. Thank you.